Let's talk a moment about the anti-suicide covenants or contracts and potential benefits of those, because there are a number of them. First, they can be a very useful adjunct to a comprehensive prevention and treatment plan, but not a substitute for such a plan. They can be a help, one step or one potential means or question, as I mentioned before, in evaluating current suicidality, particularly that notion of how long can you be sure that you can promise me that you will not harm yourself, and I usually add either accidentally or on purpose. They can be a means of reducing anxiety, both for a patient or client and for their therapist or mental health professional, if used properly. They can provide specific behavioral alternatives to suicide. Here are the things to do or the things to try in some order if you begin to feel or while you're having suicidal feelings. There are potential problems, a number of them, with anti-suicide covenants or contracts as well. One of them is the erroneous belief that a contract like that will eliminate or greatly reduce risk. It may not, and certainly will not eliminate it or reduce it just by itself. Another is assessing the competency of the patient to agree to the covenant. People who are suicidal are often not emotionally stable and may very well not be competent to make promises or decisions. Sometimes there's the use of the contract to indicate or to alleviate the anxiety of the therapist. And that's an inappropriate use of the contract if that's the only or the main reason. In addition, an anti-suicide covenant or contract is not a substitute for a solid patient-therapist relationship. That therapeutic relationship can be protective. In the absence of it, a contract is not. And overvaluation of the contract as a risk management tool can be a big problem too, when it's a part, one of several pieces of a comprehensive safety plan, then it can be useful. If one over-relies on it, it can be disastrous. And the use of the contract to reduce liability rather than as part of a comprehensive treatment plan can be a problem too. Thinking that by having the person sign a contract that will absolve you as a helping professional from any responsibility for their actions is not a wise way to go about a safety plan. On the screen, you'll see a sample of an anti-suicide contract. This is only one sample, and it's certainly not the be-all and end-all. It gives you an idea, a framework from which you can develop your own, but there are several things that are important about the contract. One is that it should imply a certain time frame. In this case, as long as I'm a client of so-and-so, or you might modify that time frame. It should include a covenant not to harm oneself, either accidentally or on purpose. And it should include alternatives in case the person begins to feel that they can't keep that promise. It should have as one of those alternatives going to the emergency room if necessary. And it should include some indication of how the person or others associated with them are going to remove lethal means. Finally, it should be signed and witnessed so that it has the appearance of a contract or gives the appearance of inviolability. What works? What do we know from research that actually makes a difference, that clearly has a research base for suicide prevention? There are three basic things that we know make a difference. That doesn't mean that other things can't or don't, particularly in individual cases. But across the board, patient education, gatekeeper training, and restriction of access to lethal means all consistently make a difference throughout the research literature. It's so important to educate people about alternatives to suicide and what to do if they begin to experience suicidal feelings. It's important to train others to be our eyes and ears and to train trainers so that everyone that we can possibly get involved to be helpers in monitoring for suicidality learn how to do so and learn how to do so effectively. And restriction of lethal means we've mentioned several times. That is clearly an effective method for helping to reduce suicidal risk. Another issue that needs to be addressed in suicide prevention is the issue of media coverage of suicides in the aftermath. Here's an example of a poor quote from the media in the aftermath of a suicide. This person was a well-known performer, and the media wrote, "He was a man who gave all he had to give to everyone around him, whether family, friends, fans, or strangers." The family said in a statement relayed by police Wednesday, "He gave as long as he could, as best he could, and he was very tired. We take comfort in knowing that he is now at last at peace." I certainly can understand why the family would take comfort in that feeling, and I certainly can understand why they might give that message to the media. But I can also understand how that might be misinterpreted, and misinterpreted fatally, by some vulnerable people who are exposed to that particular media reference. Here are some recommendations for the media for reporting suicide, and these recommendations come from a collaboration between the Center for Disease Control and Prevention and the American Association of Suicidology, and they are recommendations. By the way, these are available on the website, and you can see the web address on the slide here. These are important to communicate to the media prior to their reporting of a suicide, prior to the occurrence of a suicide if possible, so that they'll have an idea of the guidelines and how to be responsible in their reporting. And it is important to remember that most media members do in fact want to be responsible. Some of them don't yet know how. It's important to convey that scientific evidence exists that media coverage can contribute to the causation of suicide, but can also contribute to prevention of suicide, depending upon how it's handled. Media coverage can contribute to contagion, but it can help prevent that contagion. Health professionals and public officials shouldn't try to tell the media what or how to report about a suicide, but public officials and the media should consider carefully the impact that their messages will have on others. And they should think carefully about how to report in the aftermath of a suicide. Here are some aspects of news coverage that can promote suicide contagion. For example, presenting simplistic explanations. We rarely know why a person committed suicide, certainly not in total, and simplistic explanations can tug at the heartstrings of individuals who might be contemplating suicide themselves. Engaging in repetitive, ongoing, or excessive reporting of suicide. You probably have experienced yourself the negative impact of repetition of disastrous events in the media. Providing sensationalized coverage of the suicide, including how-to descriptions about committing suicide. Glorifying suicide or the persons who have completed it is not appropriate for the media. And focusing on the positive characteristics of the suicide completer may not be helpful. Doesn't mean that the completer should be vilified, but it would be more helpful to say that the suicide is in part a result of poor problem solving or erroneous decision making on that person's part. Here on the screen, you can now see some of the resources that are available for those who are contemplating suicide. For example, the 1-800-SUICIDE number can link one currently to people who can help. However, that number will, before long, be out of existence and has already been replaced for most common use by 1-800-273-TALK. And so I would suggest that that's the hotline number that you give to most of your clients or patients who might be suicidal. Then there's a particular hotline for the deaf, 1-800-799-4889. There's a 211, an emergency number that will connect the individual to the nearest response center for helping them to prevent suicide. Then there's an online suicide prevention lifeline at www.suicidepreventionlifeline.org for those who might prefer online access. And there's suicidehotlines.com. And for GLBTQ clients or patients, the 1-866-4U-TREVOR hotline. And there's the trevorproject.org. So there are a number of alternatives available. Here's a list of resources: the American Association of Suicidology, the National Center for Injury Prevention and Control, the National Mental Health Information Center, Suicide Awareness Voices of Education, the Depression Center, the U.S. Surgeon General's hotline online site, and at that site there's the call to action to prevent suicide and facts and figures about suicidality as well as suggestions for prevention. And Yellow Ribbon International is also a very useful resource. You can see the references on this page, and these are just a sampling of references that may be helpful to you. And, of course, even though this was a rather lengthy presentation, it's just the tip of the iceberg. This is just the beginning for learning about suicide prevention. I want to thank you for your attention and wish you a good day and a safe day.